Hello students, my name is Liz Attia and today's topic is the exceptions to autonomy. Okay, so principle-based ethics and autonomy exceptions. So the first exception to informed consent is under this doctrine of emergency. So clearly if a patient is incapacitated because of the nature of the emergency, unconscious or in pain, or in shock and unable to give consent, a practitioner at law may initiate the treatment he or she deems to be reasonable and necessary in an emergency circumstance. Now, just take note here that the intervention or the treatment is only permissible insofar as it actually stabilises the condition of the person. So if an emergency is defined as treatment necessary to save the life or prevent serious injury, then by virtue of that, the treatment that's deemed to be essential then is only to actually stabilise the condition so as to save the life or prevent serious injury. It's not to extend beyond that threshold. Interestingly, it's a misconception, but not many people know this. There's in fact no legal requirement to gain consent from a relative in an emergency situation. So whilst from a risk minimisation perspective, it's always a good idea to try to actually get it, at law, it's not a requirement. The practitioner will, under the doctrine of emergency, have the legal right and legal permissibility to save the life or to prevent serious injury in an emergency situation. There's also different types of consent. Generally, a contract of service between a patient and a health practitioner is implied. Consent to touching a patient shouldn't, however, be assumed, and valid consent should be obtained prior to initiating and touching a client. So without consent, then it exposes the treating professional to an allegation or potential allegation or potential charges rather of trespass to person or assault or battery. So if a practitioner treats patients alone, they run the risk of being falsely accused. Whilst implied consent can sometimes be inferred, given the circumstances, it's always better to try to actually get consent in writing. What we mean by implied consent is consent by action or inaction. Consent which can be inferred based on the particular dynamics and what the patient or the client actually did in those circumstances in response to what the practitioner did or didn't do. So it is contextual and it does require an examination of the facts or the particulars of the situation, such as if I actually say to a patient, may I please take your pulse, and they roll up their sleeve and give me, stretch out their hand or their forearm, then in that's implied consent through their body language, through their physical response to my request. Okay, written consent is required in particular circumstances. It is important to note that a patient may alter a consent form prior to treatment, and a medical practitioner may also refuse treatment on the basis of that alteration. So a patient may withdraw consent at any time, and written documentation of this withdrawal should occur where possible. I do draw your attention at this point to the fact that, as I mentioned before, consent must be specific. It's not good enough to actually get a general consent form that actually says that the patient or the client agrees to intervention without stipulating specifically what that actual intervention is. It should also not be assumed that signing a consent form establishes valid consent, because there are other elements of consent which need to be substantiated based on the validity and based on the competence criteria, which I pointed out to you in the last lecture. And I draw your attention to that. So beyond informed consent, autonomy may also relate to other issues, such as choosing one's own doctor, such as actually getting a second opinion, such as, private and public health, that public and private health scheme, such as the ability to actually seek intervention through complementary or alternative therapies. And I guess I'd ask you at this point just to consider in our biomedical model of service delivery in the Australian healthcare system, where the complementary and alternative therapies and medicines are widely accepted by the medical fraternity and the biomedical allied health professional sphere, and whether in fact second opinions are encouraged and whether they're promoted, or whether we do still find in practice some residue of this paternalistic expert type role that health professionals sometimes find themselves in, where in fact asking for a second opinion is considered to be offensive or in some way challenges the veracity or the credibility or the integrity of the that health professional's relationship with the client. So just I guess consider that, because these are some of the practice implications which make a difference to how these principles are actually given meaning in real life practice. Thank you, students. That brings today's topic to an end.